Good afternoon, everybody, and good morning to our friends on the West Coast. I am Sarah Dash, President and CEO of the Alliance for Health Policy, and I want to welcome you to the 12th week of our COVID-19 webinar series. For those who are not familiar with the Alliance, welcome. We are a nonpartisan resource for the policy community dedicated to advancing knowledge and understanding of health policy issues. We launched this series to provide insight into the status of the COVID-19 response and shed light on remaining gaps in the system that must be addressed to limit the severity in the United States. This pandemic has disproportionately affected Black, Indigenous, and people of color communities. Existing data shows that people in those communities are more likely to contract COVID-19 and are at higher risk of being hospitalized or dying from the disease. In a moment, our panelists will explore some of the root causes of these disparities and discuss policy options to advance equity and improve COVID-19 outcomes. The Alliance for Health Policy gratefully acknowledges the National Institute for Healthcare Management Foundation and the Commonwealth Fund for supporting the COVID-19 webinar series. And you can join today's conversation on Twitter at #AllHealthLive and follow us at All Health Policy. We want you all to be active participants, so please get your questions ready. To ask a question, please use the speech bubble icon on the right-hand side of your web browser. You can also use that icon in case you're experiencing any technical issues. Finally, check out our website, allhealthpolicy.org, for background materials and a recording of today's webinar, which will be made available there soon. And now I am so pleased to introduce Dr. Lori Zephyrin, Vice President of Delivery System Reform at the Commonwealth Fund, who will moderate today's discussion. Lori, thank you for being here.
Thank you. Thank you so much, Sarah. I'm so honored to have this conversation with all of you today. We're in a moment of time that highlights the dual pandemics related to COVID-19 and structural inequities attributed to systemic racism. What we are seeing unfold in front of us is a compounding of already existing inequities that are heightened when you add a pandemic to the mix. In addition to the health harms, there's widespread economic and social disruption that harm those most vulnerable to inequity. What we see on this slide, next slide, the reddish and orange colors here indicate states where deaths and cases are more than proportional to Black people's share of the population in each state. The disparate rates in deaths and cases are striking. And if we go to the next slide, these inequities go beyond the African American community. They touch other communities of color, with striking disparities existing for American Indian and Alaskan Native populations. For example, in Wyoming, 30% of cases compared to their making up only 2% of the population. For Latinx people, rates are 2 times higher in 30 states and 4 times higher in 8 states. There's still additional data needed, and we don't see the full extent. There's major holes that remain, where almost up to half of cases still have no race or ethnicity data tied to them. New efforts for data collection and new administration requirements may help fill the gap for states to report COVID-19 data. So from the time COVID-19 took hold in the US and community spread of the virus became known, communities of color have been disproportionately burdened by the disease. If we go to the next slide, we really have to understand the conditions that perpetuate these disparities and frame the policy solutions to address these issues. COVID-19 is devastating communities, and as a society, we cannot ignore the root causes. These disparities arise as a result of systemic inequities that affect where you live, where you work, your ability to access healthcare, and how you're treated when you get there. We have a true moment now where there seems to be a collective understanding of the value of health and what health means and the structural and social impacts that affect health. With that frame in mind, I would like to introduce our panelists for this session. Today, we have 3 extraordinary individuals joining us in this conversation about COVID-19, health inequities, and opportunities for action, particularly from a policy perspective. Today, I'm pleased to be joined by Dr. Rachel Hardiman, Associate Professor at the University of Minnesota School of Public Health. Dr. Hardiman is a reproductive health equity researcher who uses the tools of population health science and health services research to describe a critical and complex determinant of health inequities, racism. Next, I am pleased to introduce Dr. Wisdom Powell, who's director of the Health Disparities Institute and associate professor of psychiatry at UConn Health and president of the American Psychological Association Division on Men and Masculinities. Dr. Powell's community-based research focuses on the role of modern racism and gender norms on African American male health and outcomes and healthcare inequities. Finally, we have Dr. Adeze Inequities, president of Impact International and a board member of the Alliance for Health Policy. Dr. Inequities is a leading voice in health policy and the social and structural determinants of health, working to create an equitable care system that makes meaningful changes in people's lives. Thank you all for joining us today. Now I'm pleased to turn it over to Dr. Rachel Hardiman. Dr. Hardiman?
Good afternoon, everyone. And thank you to the organizers for having me. I'm really happy to be here and to discuss this important issue with you all today. I'm going to start with a few comments just to frame where I'm coming from as we think about this issue, and I look forward to the discussion that we'll have over the next hour. So we've all heard the words over and over in the past few months that we are in an unprecedented time in our country. And while that may be true for some of us, for those living in Black and Brown bodies and Black and Brown communities, many of the daily headlines of the disproportionate impact of COVID is not new news. It's business as usual. I recall in February reading about the novel coronavirus for the first time and thinking, if this hits my community, it's going to be bad news. And certainly that's exactly what we've seen. As you just heard from Lori, overall, Black Americans have the highest mortality rates and most widespread incidence of disproportionate death related to COVID-19, making it such that 1 out of every 1,625 Black Americans in the general US population has now died from COVID-19. We also know that Indigenous people are dying above their population share, particularly in places like New Mexico. It's not a coincidence that the two populations in our country that have bared the physical burdens of centuries of injustice are dying and are contracting COVID at disproportionate rates than that of their white counterparts. And at the root of these illnesses and deaths is a history and legacy of racism in all of its forms, from internal, internalized, institutional, and structural. Today, I'll mostly talk about structural racism, and that means the totality of ways in which societies foster racial discrimination through mutually reinforcing systems of housing, education, employment, earnings, benefits, credit, media, healthcare, and criminal justice, as defined by my friend and colleague, Dr. Zinzi Bailey. These patterns and practices in turn reinforce discriminatory beliefs, values, and distribution of resources. And as we think about policy interventions, a focus here is going to have the greatest impact. What we must recognize is that the social determinants of health, as you just heard, those conditions and the environments in which people are born, live, learn, work, play, worship, and age, are not just important indicators of health and well-being, as my field of public health has so well described over the years, but that these determinants are rooted in structural racism. So where one is born, lives, works, and plays is rooted in legacies of segregation and white flight, practices of gentrification and environmental racism, and local zoning ordinances, all of which in aggregate confine Black and Brown people in residential areas where we are disproportionately exposed to toxins and pollutants. As a result, Black populations have higher rates of asthma and cancer, and recent data suggests that chronic exposure to particulate matter in the air may contribute to risk of death from COVID-19, as much as 15% higher for Black Americans than that of their white counterparts. We must see all policy as health policy, and as my colleagues, Dr. Medina and Dr. Boyd and I describe in our recent publication, Stolen Breaths in New England Journal of Medicine, we have to understand that the social determinants of health at their root have racism as that fundamental cause. And as my colleague and mentor and friend, Dr. Monica McLemore says all the time, this could all be different. And she's right. It's time to deploy solutions that meet the urgency of the moment we're in. These solutions must have equity at the forefront rather than retrofitted on the back end. And they must explicitly value Black and Brown lives with the understanding that if our communities do better, we all do better. And this begins with divesting from racial health inequities. Racial health inequities are not signs of a system malfunction. Rather, they are a byproduct of healthcare systems functioning as intended. So what I think is unprecedented about COVID is that we are in a moment where it is increasingly clear what does not work. And we have the opportunity to build a new system that values Black lives. And I look forward to having a discussion with you all in the next 45 minutes about what that can look like. Thank you.
Thank you so much, Rachel. Now I'd like to turn it over to Dr. Wisdom Powell.
Thank you for welcoming me to the panel and for the opportunity to talk with you today about some of the issues that we are observing here in the state of Connecticut, which have bearing on the conversation that we're having today. And I'm hoping that folks can see my screen.
Yes, we can.
Thank you. I'd like to use the frame set up by a philosopher, Heraclitus, who first remarked that you can't and could not ever step in the same river twice. And while there are many probable interpretations of this now famous quote, I will offer that rivers, even with different currents and different waters flowing onto you, still offer an opportunity for us to, in fact, step in that same river. And if history is a good teacher, as we have been told, then the Spanish flu pandemic of 1918 offers wisdom about pitfalls and missteps that might more effectively guide our COVID-19 response strategies. As you know, during this time, this unprecedented influenza pandemic claimed more than 600,000 American lives. And even though we know that these lives were lost, and we know that even at this time, at that particular time in our history, we saw for the first time a sort of flattening, if you will, of the influenza mortality curve for Blacks. Some offered that this decreased mortality was related to more physical soundness or hardiness, but in hindsight, we're reminded that testing and treatments at that time were also unevenly distributed, that rates of infection and mortality were not consistently tracked and monitored among Blacks, and that even while we were observing this reduction in mortality, we're still seeing marked racial differences in the distribution of resources and the quality of care and an exposure to systemic dehumanization and neglect. And because we didn't center these root cause explanations or lenses as we were exploring opportunities for recovery and response, we didn't track and monitor and focus on the pre-existing social inequities. And so we were less prepared for what we saw only a year later, and that was an uptick in mortality among Blacks to not only surpass whites, but to return back to the prior rates. So we failed in 1918 to center equity, and more importantly, health equity in our pandemic response strategy. And so here we are standing at the mouth of a similar river. When we talk about health disparities in this conversation, we often forget that really the goal here is to advance opportunities for everyone to have a fair and just opportunity to live their healthiest. That while we're talking about disparities, we really need to be talking about how do we move the needle on systems, policies, and procedures and practices that lead us to exacerbate pre-existing disparities. We forget that the disparities that we're observing both pre-COVID-19 and now have significant implications for healthcare spending and worker productivity, and thus impact our capacity to compete in the global marketplace. That this is not a zero-sum game, that in fact, when we invest in those groups who are most affected by disparities, we actually create a broader social impact that creates a healthy community opportunity to live a fair and just life. We also know that, as our colleagues have pointed out prior to my comments, that COVID-19 is disproportionately impacting minority communities. But we also know that those data are somewhat incomplete. And because we don't systematically collect data that are disaggregated by race, ethnicity, language preference, and other demographics, we're not getting the proper diagnosis that will fuel a tailored and effective intervention response. While we're talking about disparities affecting minority communities, it's important to note that in several states across the US, we're seeing data emerge to suggest that women appear to contract the virus at higher rates, but death rates are highest among men. And this is important to lift up because, as we know, that in our country, despite medical innovations and advancements, Black males still live the shortest lives of all individuals in US society, creating a perfect storm for exacerbated COVID-19 disparities in Black and brown men. There are opportunities, as we've been discussing, for legislative action. I believe where there is political will, there is a legislative way. And so we are committing ourselves to the systematic collection of race, ethnicity, and language data, then we're better positioned to make a dent in moving the needle on health equity. We know that there are opportunities that exist within existing healthcare policy. For example, Medicaid expansion, which offered for the first time in our history an unprecedented opportunity for low-income and childless men to come onto Medicaid rolls. And in data that we examined from North Carolina, a non-expansion state, we discovered that if North Carolina had expanded Medicaid, that they could have potentially reduced the deaths of Black men from colorectal cancer significantly. We have opportunities to deploy and reimburse community health workers, revisiting our metrics and our strategies for reimbursement and paying for value. We also know that we can center health equity by focusing on those who are most vulnerable and thinking about especially the double threat to health outcomes that are produced in communities that are already facing systemic injustices and inequities due to race, ethnicity, and other demographic identifiers. We know that there's a reason that we have these inequities that are not about individual behavior, that are not rooted in genetics or personality or biological substrates, that in fact a fundamental or root cause of health disparities related to COVID-19 and pre-existing disparities are linked to long-standing racism and discrimination both inside and outside of healthcare systems. And while we're talking about disparities in Black and brown communities, we have to remember that there are other shadow pandemics operating in the background. We know, for example, that racialized violence that is experienced by communities of color and even everyday racism has a diminishing impact on the trust that individuals bestow in health systems, so that when we build them, they will not come. And the pandemic in of itself has introduced potential trauma that is felt collectively by all of us who have been forced to shelter in place as we try to flatten the curve. And so as we're thinking about same rivers, I hope that we're thinking about the need to pay attention to the potential fallout from chronic disease, morbidity and mortality, and mental health impacts of COVID-19. And so that we, in fact, resist the natural tendency to step in the same rivers twice. And I look forward to having a conversation with all of you.
Thank you so much, Dr. Powell. A powerful analogy around the strong rivers, and Dr. Hardiman saying, you know, we're in a moment where this is clear and we know what we need to do. So Dr. Inequities, I'm turning to you now, really looking forward to your thoughts and comments.
Thank you so much, Lori, Dr. Zephyrin, and it's wonderful to listen to Dr. Powell and Dr. Hardiman give such wonderful introductions. I do want to take this moment to thank the Alliance for Health Policy for putting on this particular webinar, but really for their series around the many issues around COVID-19. Hopefully everyone listening today will take something or two away from this conversation. I have certainly found them to be most informative and helpful in thinking about policy. So thank you to Sarah Dash for just this, skilled steering of this organization, especially at this difficult time. I do want to center a couple of my comments around policy implications. A lot of our listeners hopefully are from members' offices, senators' offices, different agencies within the executive branch, people young and seasoned who are in a position to craft the future of our response and what it looks like from a whole host of angles, whether it's research or funding and investments. And I think as we're speaking about this issue, we want to be better positioned so that we don't keep making the same mistakes. I think the statistics speak for themselves. Black people are infected and die at disproportionate rates than their white counterparts. We are seeing the exact same statistics among other people of color and minority populations. And it doesn't, I think what's worse is that we're not going to get a break this summer. That's actually what the data are pointing to. COVID infections continue to spike. And with the spike in infections, we have the lagged indicators that will show up in a few weeks around hospitalizations and the inevitable deaths that will follow. New models are actually predicting that in a couple of months, 200,000 Americans would have died from COVID-19. If you compare that to Wisdom's slide just a few minutes ago, where we lost 680 something people from the 1918 flu, that's 100 years later, and it doesn't look like we have made really significant progress in our ability to handle, infectious respiratory diseases that, for which we have no cure. What we do have, however, are stronger, better public health interventions that simply require a decision around how we deploy those interventions. The United States is unique in this dismal outcome. COVID-19 affected, I think, spared no corner of the globe, and yet we are seeing outcomes in the richest country in the world that look like what you might expect to see in a much poorer developing country context. These results are not inevitable. At the same time, we can't continue to admire the problem, especially when we're talking about health disparities and health inequities. I'm old enough to have been doing this for more than a decade, much longer than a decade. And I know that the literature around health disparities, health inequities span over a century. Knowing the statistics won't, as important as they are, and we need to know them, but it turns out it won't lead us to solving the problem and addressing what we need to do structurally to combat the next pandemic, the next natural disaster, or the next public health crisis. What we need to do, however, is, again, with the engagement of all of the relevant bodies, whether it's academics, researchers, policymakers on the Hill, executive agency staff, et cetera, is to really articulate what the vision is for this country when we do encounter the next natural disaster. I think I hope that our conversation as we move forward, we really focus on empowering our citizens, educators, so that we make better decisions that are rooted in evidence. We make better decisions around data collection. It is mystifying that decisions have been made to not collect race, ethnicity, and limited English proficiency data 10, 15 years ago. We had toolkits around how to do that better. The IOM Unequal Treatment Report came out, I believe it was 2002, 2003, articulating the necessity of this as part of health services research and health policy. So I think at the end of the day, what we're talking about are better decisions by policymakers tied to accountability measures so that everyone is incentivized to do the right thing and to think about health equity as the primary lens through which we deal with public health crisis, because we know what the inevitable outcomes will be. And I think with that, I'll pause and transition back to you, Lori, for our conversation.
Thank you, Adeze. You're absolutely right. Health equity has to be a critical part of any policy decision, better decisions and better accountability. And I think as Rachel and Wisdom and Adeze highlighted, health disparities are not a new phenomenon. We really have to act intentionally to eliminate these disparities, we have to look at the data. We have to apply a health equity framework. We have to think about how we allocate dollars, how we expand coverage, and how do we ensure that any policy or legislation that moves forward considers equity and measures the impact on communities of color. And so we're really looking forward to your questions. And so I'll start out with Dr. Hardiman. You know, I'd love to get your thoughts around healthcare and health policy that's often structured in silos. And I think Dr. Powell wisdom painted a picture of the connection between structural racism and the COVID-19 disparities and police brutality and the impact on those most vulnerable to inequity. And so, you know, I'd love for you to talk a little bit about the disproportionate incidence of maternal mortality in Black women. Also has sparked a national conversation. And how are these conversations similar? And what can we learn from the drivers of the disparities, and what are the policy options to overcome them?
Sure, thanks, Lori. So I think you're exactly right. You know, we've seen this disproportionate incidence of maternal mortality in the U.S. and we know now that Black women are 3 to 4 times more likely to experience maternal mortality, and that's led to a lot of conversations and legislation and policy interventions to do something about that. And all too often, the conversations are centered in these silos, as you described, where public health is doing their thing, medicine's doing their thing. And I think one of the other important pieces or problems we face is that we all too often aren't viewing health policy as our social policy as health policy, right? So we're not thinking about the connections between things that we wouldn't necessarily deem as specifically as health policy. But what we've seen, particularly I think with the Black Maternal Health Momness Act of 2020 is, an incredible amount of thought and work that's gone into sort of bridging that gap in order to be really thoughtful and really intentional about the rising maternal mortality rate in the U.S. and the Black maternal mortality crisis in particular. And so, we see different, different ways that legislation can improve that crisis in our country. And I think a lot of the pieces of that act, if you look at sort of the nine bills that were put forth in the Momnibus Act, a lot of them apply to what we're facing right now with respect to COVID-19 and the disproportionate impact on Black and Brown communities. So everything from, the Social Determinants for Moms Act, where, we're asking to make key investments and advances in critical research on the social determinants of health, and to really think about how all of these social factors, as we've heard before, where you live, work, and play, impact health. Pieces of other pieces of that act, like the Justice for Incarcerated Moms Act, and the need to, the call for the need to study and understand the scope and impact of maternal mortality in incarcerated populations, just as we are seeing, significant impact of COVID-19 in incarcerated populations and correctional facilities across our country. And certainly that ties into and cannot be disconnected from the current cries for change around police reform and police brutality and the criminalization of Black and Brown bodies in our country. So I think that there's a lot to think about with respect to legislation that has already been put forth, right, to deal with other crises, because it's all part of the same root and the same foundation of structural racism. And so leveraging, the deep knowledge and the expertise of folks working in all of these spaces is critical to address the COVID disparities issue as well.
Right. Thank you. And it seems that Dr. Powell, Wisdom, your comment around stepping in the same river twice really applies. So a question for you, Dr. Powell. You mentioned community health workers. How can policymakers ensure that we invest not in just short-term tracking, tracing workforce more broadly, but in an expanded community health care workforce that can tackle the underlying morbidities and disparities that we're seeing?
That's an excellent question, because I think we do have to reimagine what our healthcare workforce is going to look like, because first of all, we're not training enough racial and ethnic minority physicians, nurses, healthcare workers to begin with, and not at a rate that would match the need in racial and ethnic minority communities. So we have to think about all the levers we have at our disposal to expand the workforce. And so community health workers, who have always played a critical role in bridging communities of color to health systems and providers, could play a really prominent role in our recovery and response efforts, and also could be leveraged again to support us as we address the potential chronic disease fallout. And as I alluded to in my comments, one of the concerns I have and many leaders have is that because of the physical distancing requirements, many people were foregoing their routine preventive screenings, and were not able to, be in touch as they routinely or normatively were with their providers. So chronic disease management, we fear some chronic disease management may have fallen through the cracks. And so if we think about our community health workers as a part of, as an important arm of the health system, then we could leverage their talents and gifts to support us in reaching out to folks around preventive screenings, right? To help meet community members where they are, where they live, they work, they play, et cetera. And to reimagine what a workforce development / economic recovery strategy could look like if we were to open up new pathways to community health worker certification for men and women from communities of color who have been edged out of employment opportunities as a part of the pandemic. So we have to get creative, I believe, and there are lots of opportunities for us to expand the reach and impact. I mean, when you travel abroad to other countries, you see a more creative use of community health workers, and also more impact and return on investment, if you will, for making those resource allocation decisions.
Absolutely. And, there's a lot of data just showing the impact, as you mentioned, of community health workers, and really that connection to the community at the heart of health, at the heart of primary health care. Thank you. How would you address the feeling of urgency and impatience felt by so many living and working in hard-hit communities? It's hard to deny that structural racism wrought by the way the U.S. healthcare system is organized and financed as a commodity rather than a social or public good. Are we on track for transformational change? Is this even possible?
Lori,
Go right ahead.
is this directed at me, Lori? I wasn't sure.
Yes, Dr. Inequity, yes, please.
Oh, okay, and Adese is just fine. It's a great question. There are many reasons for why this is urgent, or at least more urgent. And I think it speaks to the fact that for some who may not have been paying attention to health equity, or if you haven't been steeped in this research or policy area, it might sound like this just bubbled up to the top, a year or two ago. But I think, as I mentioned earlier, we have a century of work, at least, where people have been talking about this. Initially, it didn't even start with race; it started with class. Poor people versus, the gentlemen in England, the workers, and the folks who get their hands dirty, their nails dirty, versus the people who never have to touch soil or iron. So, and you find that there are great differences there. So we have a lot of factors that intersect, that lead people of color in this country and in many others, but in this country, we'll focus on people who are vulnerable for a whole host of reasons around education, income, and wealth, where they are persistently at a disadvantage when it comes to access to resources, access to care, access to quality care, and hence poor outcomes with respect to their health. So my hope is that we will seize the moment. I think it was Wisdom who mentioned that, the protests that have arisen because of police brutality and the life and death situations that occur when Black men in particular encounter law enforcement has spread to, I think there's a trending Twitter handle called Black Ivy, or Black in the Ivy, or Black in the Ivory Tower. Black academics, people who are seen to have made it as in quotes, when they come out and talk about their experiences and what it has taken for them to make it, or how they've made it in spite of significant roadblocks, I think starts to lend credence to this notion that we have a lot of work to do in virtually every facet of American life. What it will take to seize this moment appropriately is leadership. That to me is the underlying factor. If you don't have people who can think about this and the implications and think beyond the next win in a month, but think about the long-term implications in the next 10 years, in the next 20 years, and really begin to get us on to the place where we've got a strategy moving forward, then we will miss the moment. So I do believe that with the confluence of voices, if you will, coming from every corner in our society, we do have a wonderful opportunity. It doesn't come around very often, where you have not just Black people speaking out against injustice or Hispanics speaking out against injustice, but everyone, lots of white people are protesting, because I think there's a collective recognition by many that the current state is just not sustainable. I do, if you don't mind, Lori, want to go back to a question that you posed just a minute ago, because I do think something is worth clarifying. Why do we need more people of color in the healthcare workforce? I think when we talk about it amongst ourselves in the policy space or academic space, we take it for granted that the reason for that is understood. And I'm starting to pick up that it's probably not understood. I think it's helpful to just tease that out. People of color, people from particular communities, are much more likely to go back to their communities after training. So if someone from a rural part of Missouri goes to medical school, they are much more likely to go back and serve and take care of patients in that rural part of Missouri. Rural advocates know this and have been doing this grow your own when it comes to nurses, nurse practitioners, PAs, and physicians for decades. The same thing applies to communities of color, because what you engender is you develop a trusted partner for that community, someone that members of that community will trust, someone who understands them, understands the nuances and the idiosyncrasies related to that particular community. For people of color, you have the added ability to combat the long history and abuse and antagonism, the long history of abuse and antagonism by some members of the medical community against communities of color. We have a long history, I'm sure most people on our call are quite familiar, of Black people being experimented on and having effective and efficacious treatments withheld and not being served as well, being disrespected. If Rachel Hardman is talking about maternal mortality, and when you listen to Black women talk about their experiences with disrespect, with not being believed, with not being treated for pain, it just goes on and on. This is not historical. When COVID-19 broke out a couple of months ago, we saw some French doctors on camera casually discussing experimenting on African children, or I think it was Africans in general, unproven treatments that may or may not kill them. The safety and the harm profile of those drugs were not being discussed. They were just going to, the conversation was so casual that it was shocking. So this isn't in our history. It's not in a rearview mirror. There's a reason why we keep talking about the need to have more people of color in the medical profession and health professions and health policy professions, because without a representative group of folks at the table, you find that communities of color will continue to suffer from, you know, the inequities we're talking about.
Thank you, Adeze. And that leads very nicely into this next question. And we're getting a lot of questions from the audience, so thank you for your engagement and interest. Rachel, I'd love for you to answer this question as well, just also talking from your experiences in Minnesota and the work that you're doing around anti-racism training in healthcare. Can you comment on how historical distrust of the health system is playing out in this pandemic, in public health efforts, for example, especially around contact tracing or other public health efforts? What can local health departments do to improve community relations? Rachel?
Yes, thank you for that question. I think it's such an important one. You know, so I am a Minnesotan and born and raised here and currently living here. George Floyd was murdered by a former Minneapolis police officer 8 blocks from my childhood home. So in addition to what we've seen, the impact that this has had on the country, you know, it's a very real part of my life right now. And you know, what we know is that this is a community, these are the communities that are already disproportionately impacted by all of the, you know, the long list, the laundry list of health inequities in our communities. And we also know from research that I've done with Dr. Syria Long at Lehigh University that folks who report having any sort of negative encounter with police, so even an encounter that they deem as a necessary encounter, they are more likely to report having mistrust in medical institutions. And I think understanding that and what that means for this current moment we're in, both, you know, with respect to COVID and with respect to structural racism and how it's playing out through police brutality in our communities, is incredibly important, because what happens then is, you know, this potential risk that folks who are out in the streets protesting, as they should be, you know, are certainly, you know, potentially exposing themselves or putting themselves at greater risk for COVID-19. And this mistrust may lead to, you know, hesitation to get tested, hesitation to engage with contact tracers. And so here in Minnesota, I think, you know, we have some great folks who are thinking about these issues and are working on and have set up, you know, opportunities for, you know, testing in communities and really making sure that that is available in the communities where protests are happening. I think Dr. Powell's mentioning of the use of community health workers is a really, really important point. We know that community health workers have built trust within the communities and often come from the communities that are most impacted. And so thinking about ways to keep people safe and healthy through community health workers, I think, is incredibly important. You know, we're working here to make sure that COVID testing is accessible and straightforward and free, and that people understand that it's free, and that you know, they can decide how to get the results. So, you know, making sure folks know we can send you a text if you know, with your test results within 72 hours. And so all of that, I think, is really important. But, you know, if we're not coupling that with sort of bigger policy initiatives around that protect communities and protect people, then it's sort of a moot point, right? So if we don't have, you know, hazard pay, and if we don't have paid sick leave for the folks who we know are out there protesting and fighting for their livelihood, but also are the essential workers working in grocery stores and working in places where they are going to be more likely to be exposed, then, you know, what we're doing on the ground isn't going to have the impact that we need it to have.
Thank you so much for that. And some other questions around, and I think these can go together. I'll try to collapse some of the questions just given the time. You know, what role does you know, what do we know about, for example, disparities in other countries? Is the U.S. an outlier? what do we know about, other continents that are having variable incidences of COVID-19 wisdom? Can you give us some insight on that?
So I'm going to speak from the perspective of talking about men's health, which is my area of expertise, and then I'll invite, of course, my esteemed panelists to weigh in on some other statistics. But here's what we know, that around the world we see males dying more prematurely from chronic disease. They have shorter life expectancy relative to women, and while there might be epigenetic and also genetic factors, biological factors contributing to these disparities, we know that they're not all rooted in biology, because if they were, then we would see those same disparities across patterns of disparities across groups of men from all racial and ethnic minority groups, and we don't. So I like to lift up the not so spurious case of George Floyd, right, where we have a Black man who actually happened to escape the grips of COVID-19, recovered from COVID-19, only to perish as a consequence of racialized violence, right? And so what this speaks to me, in linking this back to the conversation about trust and how we turn a corner on disparities, is that we have to remember that mistrust in medical organizations by men like George Floyd and other Black men in the country who have reported higher levels of mistrust is not an attitudinal barrier, right, but a legitimate response to systematic maltreatment. And that mistrust thickens and thins with cumulative interactions with systems and individuals. And all the research that we've done over the past 20 years among Black men linking mistrust to various outcomes, we found, as Dr. Hardiman pointed out, that men who experienced more everyday racism were less likely to trust medical organizations and systems, despite other factors operating, and that this mistrust above and beyond healthcare access, insurance, and other factors contributed significantly to delays in preventive screenings. Now, why do I lift this up as we're talking about global disparities? Well, I'm talking about this because I think it's important to put into context that, while we are working to move the needle on disparities around the world, that we don't treat mistrust as simply an attitudinal barrier, that we addressed, again, the systems fractures and dysfunctions that have given rise to mistrust in populations of people who are already disproportionately impacted. I think this has implications long-term for global population health management. And if we don't address it, then when we build it, as I've said before, Black and brown populations won't come. So all contract tracing efforts will be thwarted, and people, even when we develop a vaccine for COVID-19, will not use it, will not allow themselves will not avail themselves of those services. So I think it's a serious issue. And as we think about our healthcare spending in this nation relative to the disparities, I think we should look to our global partners for different models of how we create payment structures or reform structures that actually match the issue at hand, but present opportunities for sustained change and sustained advancement towards health equity.
Excellent. Thank you so much. It sounds like trust and building empathy and better decisions and accountability, really having the framework around health equity as we think about these interventions. We have so many great questions, and we will not, unfortunately, be able to get to all of them, but we will post the resources as well as contact information for the panelists and identify other areas to do this again and explore the just amazing conversation, an important conversation that we're having today. So I think we have time for two more questions. And so one is around, what are some of the most promising initiatives you've seen to address some inequities during the pandemic or beyond? Adeze, I don't know if you want to take that one, and then we'll have a final closing question for all of you.
Sure, I can start. And I think the distinction I'd like to make is the promising interventions at scale. And because I do think, while there's utility in having a number of pilot projects that are specific to particular communities, we really ought to be thinking about what can we do at scale. And there I see a lot of opportunity. I do think in 2020, it is unconscionable that the CDC will put out reports or data where there's 50% missing data on, demographic characteristics, especially race and ethnicity. So even with the 50% that we did have, we saw that in some locales, there was, 80% of the people who had died were Black, even though they represented, a share of the population that was in the teens. So we have huge opportunities to do better. There are, I spoke with some health system CEOs yesterday and learned that, one major health system in New Jersey is seizing this opportunity to really think about reinvestments in the community. So to the extent we lacked PPE, we had pretty much every hospital that was hard hit by COVID-19 lacked the personal protective equipment, masks, gowns, etc. Why? And we were entirely reliant on a supply chain that was largely outside of the United States, manufacturing that was outside of the United States. In a global pandemic, what did we learn? Everybody will be wanting the same thing. So to the extent you're able to make your own and have them readily available, you were better equipped to handle an infectious disease outbreak. While this hospital system is thinking about investing in a community where they basically manufacture PPE, in that community, members of that community will be employed. So you're addressing our supply of PPE, something that is critical. You are addressing chronic unemployment. You are addressing the ability to build wealth over time, because these are intended to be very good and high-paying jobs and skill-building opportunities. And you start to hit at multiple birds with that single stone. It requires members of the community on the economic side, on the educational side, and of course the health system serving in this case as the anchor institution, coming together to really think about what I talked about earlier. This is not a one-year plan. We're thinking at 5, 10, 15, 20 years ahead. What I think we need to see again is leadership, where we're not continually talking and describing the problem, but to really put in place funding and investments that get us to a place where we don't want the same group of people to be at the mercy of the next pandemic or the next public health disaster. I will also say the literature on how public health disasters affect African American communities or poor communities is rather thin, surprisingly thin. We usually come out and have a lot of New York Times excellent reporting, but the etiology of this phenomenon, when those disasters hit everybody and then you see the sort of the breakdowns that occur at the societal level and then at the public health level, is not as robust as it should be, because we saw it play out in Katrina, we've seen it play out in a number of natural disasters. So we definitely need to invest a little bit more there so that what to do and what actionable things to invest in are much clearer.
Great, thank you so much. And I think you touched a little bit on my next question, which is what are some, or our next question from the audience, what are some specific legislative policies that are needed to really tackle the racial health inequities in Black and Brown communities? Rachel, do you want to take this first, and then Wisdom, and then Adese?
Sure, I will start. Thanks. I think that's an important question, and
I would start by saying, certainly universal health care, starting with Medicaid and Medicare expansion. We need to think about housing and making sure that everyone has access to housing. And, we have to think about the hospital closures that we're seeing across our country, particularly in rural communities, and also in less rural communities, but communities where predominantly African American communities, where we're seeing hospitals, closing at alarming rates, which certainly is a significant access issue. And so I think I would start with those three big picture things that are policy changes that I think need to happen. Certainly more on a local or community level. We have to be thinking again, as I mentioned earlier, about how we offer paid sick leave and how we offer childcare and things like that. So a lot of the social issues and the social determinants that are going to have a significant impact on how people are able to weather this storm, both right now, but also how it's going to set us up to be able to thrive in the long term as well.
Thank you. Wisdom?
Yeah, so I'll just lift up, I mean, so many really exceptional examples have already been given. Let me just lift up 2 points. One is around mental health parity. And while we have some legislation in place to address some of the gaps in services availability around behavioral and mental health service treatment, we still have yet to bridge that gap for populations who are at greatest risk for disparities. And so I think we have to look really hard at our policies around the provision of mental health services and create better access points for those services to be delivered to those who are in greatest need. We have to reimagine, if you will, how we're going to be deploying those services, given that we're moving more into a telehealth, a telephonic services provision environment that may be with us for the long haul. So there are many policies that have to be considered, or circumstances around the provision of those services that have to be considered. For example, many Black and Brown individuals live in intergenerational households where there's limited access to privacy, right, for a telehealth or a telephonic visit. How are we protecting the privacy of those individuals and creating care that is delivered in a comforting setting? And how do we address the broadband access Wi-Fi availability gap? I mean, we talk about smartphones, but people also need broadband and Wi-Fi to really avail themselves of those kinds of services. And then finally, I think it's really challenging for us to move towards health equity when we still have an employer-sponsored health insurance model for this nation, and that to me runs counter against what we know intuitively about underemployment and unemployment rates in Brown and Black communities. That means that many people will be edged out of, even with the Affordable Care Act provisions, will be edged out of affordable health insurance. And so we need health insurance coverage for all, regardless of employment status. And we have to be thinking about, as we decarcerate institutions in the aftermath of COVID-19, what kind of a transition assistance program or model are we setting up for folks so that when they re-enter communities, one, that we know that they're healthy and that they have a healthy place to physically distance or to be sheltered as we approach the second surge. So those are some of the policy opportunities and levers that I think we have at our disposal, and issues that I think we have to tackle.
Great, thank you. And Adeze, 30 seconds.
I know. I think I agree with everyone. I think we can't move too far forward without an expansion in health insurance coverage, whether it's through Medicaid or some of the other policy discussion points around Medicare. But I think, we need to think long and hard about that, because we're now facing an environment where lots of people have lost their employer-sponsored insurance. So that's critical. I do think we should be thinking about training and care for target populations to address this critical issue of implicit bias and structural discrimination, if you will, within the healthcare system. And of course, data collection, as I mentioned earlier, and tie those two to payment, make them and require them as a condition for payment if you're to receive federal dollars. The last thing I'll say is thinking creatively around appropriations. We can't solve social determinants of health within health alone, but we do have to think about perhaps federal investment and funding of some of these initiatives through creative means. So maybe it's Labor H as the Committee of Jurisdiction coming together with the folks at THUD, or Transportation and Housing and Urban Development, to think about a community outcomes focused investment plan, so that we're not thinking consistently in silos and are surprised when we don't get the results we want.
Absolutely. Well, thank you so much. Again, we have a moment now where there's a collective understanding of the systemic origins of these health inequities and some policy solutions that our experts have highlighted around enhanced data, targeting resources to communities in need, whether it's rural communities, African American communities, urban communities where hospitals are closing, expanding coverage, insurance coverage, mental health parity, anti-racism training tied to payment, protecting essential workers, and really thinking broadly about investing and strengthening in social supports, thinking outside of silos. Thank you to our three extraordinary panelists. Rachel, Wisdom Adeze, we're in a moment now where I think we have the opportunity to make this change, and I really appreciate the conversation, and thank you to the audience for all your amazing questions.